Hello, everyone. So my biggest problem is that I've been listening to everyone, and I have 1,000 more ideas I wish I could share with you, so I need to focus and talk about my slides for 10 minutes. And so patient-centered care, patient-partnered care, patient engagement, that's been a passion of mine for many years. And I was very fortunate to find an organization where I'm supported with many others to really focus on this, among a million other things I know. But I want to tell the story of the Ottawa Hospital. It's a large tertiary quaternary care teaching hospital in Ottawa. We have just under 1,000 beds and probably the highest volume of visits and admissions of any hospital in Ontario for sure, and perhaps even across the country. So we are massive. And I've been there for 2 years, but about in sort of an 08-09 is where this journey began. And they were redoing their strategic plan and their vision, and it already almost got to the point where they were ready to publish it, and thought they were doing, really, really well. One of the things in Ontario is that hospitals are mandated to collect ongoing patient experience data. So I moan about the fact that it's 3 months behind. When I listen to 4 or 5 years behind, I'm good. And like most other hospitals, we always had a score of 95, 96, 97, even 98% sometimes. So people thought, hey, you know what, we're doing really well. So what they developed really didn't address that. And then before they went public with their plan, Dr. Kitts, the CEO, received a letter from a patient's family member who talked about how, I think it was his wife actually, had fallen and really shattered her wrist, came into the hospital, and we put it back together, and she went home and the wrist recovered really well. But her care was terrible. And she got good medical and technical care and surgical care. What didn't happen was they didn't feel like they were listened to, that their values and perspectives were addressed or respected, and they didn't feel like anybody saw them as a human being. And that letter, Dr. Kitts now calls it the letter that changed it all, stopped, sort of put an iron in the wheel and stopped it from turning. And they went back and they re-looked at what their vision was. And the vision now, and it was renewed again 4 years later, what they created was that they wanted to provide world-class care and exceptional service and compassion in the way we would want to have for our loved ones. And that vision has stuck. And what has happened is patient-centered care, patient experience has become a priority, and they started focusing in a big way on how do we improve that and how do we become a top 10% performer in patient safety and patient care. And they set about doing a whole variety of things over the next 4 or 5 years, including measuring and managing performance, looking at how do we engage the staff and the physicians. One of the things at our hospital that I want to share with you, because it makes a difference to how we can do what I'm going to show you in a minute, is that we have a dyad structure, physician and staff members. So at the executive level, even the CEO level, our chief of staff and our CEO are considered a dyad. And all of the vice presidents who have clinical programs have a dyad partner for each program, and we don't do anything without one another. And at the unit and program levels, there's also dyad structure, which works really well in some places, and other places we're still learning. But what it shows is that we're all in this together, and there's been a whole lot of initiatives that have been put in place. So between 9-10, when they launched their vision, and 14-15, they put initiatives in place. The other thing that they did when they decided that, well, how can we get these kind of letters when our patient satisfaction is 95 or 97%. So instead of looking at the time, up until this year actually, we were using the Picker patient satisfaction survey. And everybody just thought, well, if it's good, very good, or excellent, we're good. And that's how everybody gets 95 or 98%, and nothing really ever moves. So we started chasing the percent excellent, because we knew that even though our scores were up here, we were still getting letters that said we weren't doing a great job. So over the first 8 years or 10 years, we've improved it incrementally, the percent excellent, from about 38 to 48%. And then in 15-16, I had started at the hospital the year earlier with the promise that I could provide leadership on this in connection with medicine and our quality department. And they had very, very well-oiled structures, and we have been doing many, many things. We implemented not just the patient satisfaction surveys, we use post-discharge phone calls, we do a variety of focus groups, we have patient and family advisory committees that are very structured. But we started to ask the question, our goal was to get to 70% excellent, but we kind of were stuck at that 48%. And so we thought, well, what can we do that is different? So we started to engage the clinicians a little bit. Oh, and what I also want to say is from the time that all this started until today, we have been, Dr. Alan Forster works with us, and he's phenomenal when it comes to data. So he's been building business intelligence tools and dashboards that are accessible to all of us. So on any given day, I can click on a dashboard and see where a unit patient experience scores are. Any other metric that we collect is available. They just recently launched a finance dashboard that we can drill right down into everything. So data is available, but sometimes it's too much data. And so even though it's available, that's not the end of the job. You have to push people to want to use it. And so one of the things in measuring and managing performance was that we started using a leader evaluation management tool, which everybody has what we call LEM goals. And in 15-16, our CEO tied executive compensation as well as directors and managers, everything cascaded down. 50% of our score was related to improving patient experience. We developed driver diagrams and indicators. We gave people data, but still it was too much data in too many places. So what I want to show you is what we've started doing, and I don't expect you to be able to see what this actually says. I don't even know what the questions are, but they're data points. And what we do is we map the scores from our patient satisfaction survey questionnaires on these kind of matrices. And we do it at the organizational level, we do it at the program level, we do it at the unit and team level. And right now we can also do it at the physician level. Once we get our health information system, I'm hoping in the next year or so, we're almost finished the RFP, we'll be able to connect it also to nurses and health professionals because it'll be linked through the electronic charting. And when we ask people what to focus on, so remember now, all of us have annual performance goals that right now mine, I think, first year it was 50% patient experience, now I think it's 40%. Our directors have goals and our managers have goals on the units, but they don't know what to do with the data. So everybody gets one of these, and we're asked to focus up here, right? Because low scores, high correlation to moving the overall rating of care. The overall rating of care is what's on our corporate scorecard. We only have 8 indicators on the board-facing corporate scorecard. So then we say, okay, teams look at these, pick some of the questions that are in that top left-hand box, because that's where you have the most opportunity to make a difference, and then pick 1 or 2 things that you can do to drive that. And the beauty of the dashboards is that they can track. We get monthly almost new data coming in because we continuously survey patients, and every 3 months everything gets updated, and sometimes even more frequently than that. So people can say, you know what, I'm getting 40% excellent on this question right now, and we've been doing this thing for 2 months, and now it's 45. And so they can actually see in real time when it improves. So in 15-16, we were still using the Picker patient satisfaction survey, and these were the top 5 questions that came out of organizationally out of the prioritization matrix. So you can see that availability of nurses and doctors was fairly low, and now keep in mind this is percent excellent, right? So percent top box, and you can see the other ones. And so we actually then went on to, we developed in 15-16, we implemented a brand new patient experience steering committee. And based on these, we prioritized the work of what was happening in the working groups associated with the steering committee. So this is just a quick summary of some of the groups. So I co-lead this with Dr. Jeff Turnbull, who's the Chief of Staff. The working groups are generally co-chaired by a physician and a nurse or another health professional. And the communication one was because availability of nurses and doctors, if you drill down into that, a lot of it is about communication. And we know that the number one thing we can do to improve patient experience is improve communication between nurses, doctors, other health professionals too, but mostly nurses and doctors according to the data. And so we've developed a foundational curriculum. We've got 60 physician champions who have been trained in giving feedback. And we're starting actually a campaign based on one of our physicians who's also a patient, hashtag Hello, My Name Is. Because if we start every interaction with a patient with, hello, my name is Debra, and call them by their name and ask what's important to them, that's like a first step in having a meaningful engagement with a patient or family. And then we'll drive the communication underneath that. And that group is actually co-chaired by a physician and a nurse. I'll skip research and innovation for a moment. Patient and family engagement, we have a well-oiled machine, but we could do better. So we've developed a whole new vision and mission around patient engagement. And we actually tied this work So this is all corporate I'm talking about right now. We tied this work to our quality improvement plan. So in Ontario, our quality improvement plans are mandated. We have to put one up every year and post it. And so when you post something and it's mandated by the government, you focus on it. So that's how we keep it in the limelight. I'm going to move right now to the acceleration initiatives, because that's actually at, I can't believe 10 minutes have gone by already. That's actually at the unit level. So this is actually the new survey, and we can make these kind of graphs by program. This happens to be by program and at the unit level. Every year we look to see who are the lowest scoring units, and we picked 4 this year, and we call them our acceleration units, and we put focused support behind getting the priority matrix and helping them to decide what are they going to do to drive their score up. And we've been very successful in that. And as of November 7th, using the new, 17th, sorry, using the new survey, the questions don't map. So we're in a little bit of a transition year. I can't show you the actual data from the acceleration units this year because we made our priorities based on the old survey, and we didn't get any new data until about a month ago. And they're different questions. So the groups are in the process of sort of aligning what they're doing with the results from the new questions. And you can see they do look different, and they're all new. Quickly, the physician-specific data. I know you're having an orthopedic surgeon talk in a moment, but Dr. Kathleen Gartke has done some interesting work by showing all the orthopedic surgeons in our organization their physician-specific data. And at first there was some pushback around this isn't good data, there's not enough data, but then they sort of thought, well, you know what, it's directional. And over the summer they had access to play with their own data, and every physician, every staff member gets a performance appraisal every year, and they were asked to bring their scores and a plan to address the lowest scoring ones to their performance appraisal. I think no one was more shocked than Dr. Gartke that they actually came and did it. And actually the lowest scoring physicians had some plans. And they can actually, well, once the new data gets up into the dashboard and it all becomes live again because we have a chasm, they'll be able to follow their own scores as well. And the unit-specific one, every unit in the hospital and the managers and the directors have goals. They get a matrix. They can go in and mine their data themselves. And if it's something related to, there was a question in the priority matrix last year for one of the units about how well do you think your doctors and nurses work together and understand? It's not exactly how it was worded. So we're renewing our commitment to clinical tactics, such as nurse leader rounding every day, hourly rounding by the nurses, and nurse physician rounding with the patients. And some units are doing it, and some of the acceleration units have tried that. And last year we were able to drive the scores up by about 10% on some units. Let me just go back one. This is an example of the old questions because we don't have the new ones loaded. I'm told it'll be loaded before Christmas. But one of the acceleration units last year, these were some of their key questions from the old one, and they had specific initiatives to drive a couple of them up. And you can see they can go almost monthly and see whether they had a positive or negative variance in what their scores were, and then we look at how they did over the year. So the big question is always how do you get out of the acceleration group, and it's when you get your scores up and they're sustained. And some of the ideas that they come up with, we then cycle through other groups and we spread them because they're really clinician driven at the unit level with the managers and their physician partners, and the team and quality also supports them. So it's been phenomenal. We've got so much engagement in this, and people are very positive about it. Our score improved by 10% this year, but nothing we did. It's a new scoring system because it used to be good, very good, excellent, and to get top box you had to get excellent. Now it's on a 1 to 10 scale, and people can pick 9 or 10 for the top box. And I don't know about you, but I never give someone perfect, right? So if you can give a 9, more people are likely to do that. So we're trying to figure out how to recalibrate all of our goals and be back in business fairly soon. So stop.